Great. So I'm here today with Patrick Piotie, who's the first author of a original research article called Factors Affecting the Implementation of a Complex Health Intervention to Improve Insulin Management in Primary Care, which was done in South Africa. And he and I are going to have a brief conversation about the findings and the implications of this piece of work. So, Patrick, before we start, can you tell us a little bit about yourself? I mean, who actually are you and what are you doing?
Yes, thanks, Prof. My name is Patrick Ngassa Piotie. I'm a researcher from Cameroon, based in South Africa for a number of years now. I'm at the University of Pretoria, at the University of Pretoria Diabetes Research Center. My background is medical doctor, but for the past 10 years I've been focusing on public health, having completed a master in public health, and I'm currently completing my PhD. My main interests for the past few years have been diabetes, mostly in terms of improving outcomes and having an influence so that people with diabetes in general can have a better life.
Great, no, thanks. So now what is it about diabetes and primary care and insulin that led you to feel that this study was needed?
With the team I work with, led by Prof Robert, there's been some research done previously, especially in the Swani district. And the research that we conducted about almost 10 years ago now showed that people with type 2 diabetes in primary care who were doing the worst in terms of diabetes outcome were either those who were in need of insulin or those who were already on insulin. Obviously, in the primary care sector in South Africa, patients with type 2 diabetes start with one drug and then they are moved with a second drug. And then the option of insulin is available. And the good news is that insulin is available for free in South Africa. Unfortunately, for various factors, either patient-related, healthcare provider-related, or system-related, there is that resistance to transition from oral drugs to insulin. And that leads, obviously, to poor outcome from people living with diabetes. So that was basically the motivation for us to come here with a translational research program and to try to change the picture.
Great. So now I know that you and your team and Paul Robert, I know him a little bit. You set up this Swani insulin project or TIP as you have as it's called. So what actually is it? What does it involve, the Swani insulin project?
The TIP intervention, I will share some slides with you.
Share a slide with us.
Okay, so our Swani insulin project we've started in 2018. We're working with our partner, the funder, as I should disclose, being Lilly Global Health Partnership, but we're working closely with the health authorities, mainly Gauteng Province, City of Swani, as well as the Swani district, the local authorities. Our goal was to make sure that we have an intervention that will be sustainable and that can fit into the health system as it is in primary care. So the team of researchers from the University of Pretoria, we had people from family medicine, people from internal medicine, people from sports sciences, nursing, as well as the School of Health System and Public Health. They come together after conducting some baseline surveys and audit. We realized that we need to have a multi-layered type of intervention. That way we came up with the Swani Insulin Project intervention. Without getting too much into the details, the beauty of that intervention is that it's an integrated, community-based, person-centered intervention. What we mean by that is that the person living with diabetes is at all levels the priority in that intervention. The innovation that we have here is that when a person with type 2 diabetes is identified and initiated on insulin, their follow-up is not only limited to the monthly clinic visit. we have introduced home visits, which are done on a weekly basis. So the community health worker and the ward-based outreach team is involved here to ensure a good follow-up of those patients. As you are aware, Prof, one of the great challenges with insulin is titration. In the public system at the moment, that titration happens on a monthly visit when the patient goes to the clinic. But with our intervention and bringing in telemedicine, the titration can happen on a weekly basis, meaning the patient reaches quicker an optimal insulin dose and is controlled quicker. That's in a nutshell the beauty of this intervention, and that's what we've been implementing for the past 2 years in the Swani district in South Africa.
So I see that on your slide, you talk about an app-enabled physician to help with that adjustment of the dose of insulin. How did that work, just very briefly? I think, if I remember from the article, you're using the Vula app.
Yes. So we give to our patient, obviously, a glucose machine and the test strips to control the blood sugar. They have also a diary where they note the values. We recommend that they need to test at least twice a day, in the morning before breakfast and once during the day after one of the big meals. They keep that diary with the values on it. When the community health worker visits at the home, they have the opportunity to take a picture of the values and using Vula to send them to the physician who might be located either at the clinic or anywhere else. The physician assesses the values and can give the instruction to the community health worker to increase or decrease the dose of insulin by 2 units. The challenge that we identify is that in the guidelines in South Africa, the doctor or the family physician is recommended to train the patient on how to titrate. Unfortunately, our patients most of the time are either without the numeracy skills necessary or without the health literacy necessary. So basically, that titration never happens, the self-titration as recommended. With using the community health worker, we are adding that additional support that ensure that when the doctor relay the message to the community health worker is present with the patient and can show how much more the insulin they should increase the doses before they inject. Okay,
no, thank you. So moving on to the research. So what actually was the aim of your research, and what, in very sentence or two, what was your study design? How did you go about the methods?
So once we designed the intervention, we piloted it in a few facilities, about 10 primary care facilities. Because our motivation has been to ensure that the intervention is sustainable and scalable, we decided to take a moment to reflect. We use a model which is a SWOT analysis, whereby we reflect on the strengths, the weaknesses, opportunities, and threats of the intervention as it was piloted in order to come up with strategies that will improve its implementation. So the way we did it, we had 2 groups. The people who were involved into the implementation from the project side, we call them our field workers. They did a focus group discussion reflecting on the intervention. We also spoke to the doctor, the nurses, and the patients who were involved in that receiving that intervention, regarding looking at the strengths, the weaknesses, the benefits, and the disadvantage that they identified. And that was our study.
So coming to the meat of the thing then, what actually were the strengths and the weaknesses and the opportunities and the threats? What were the key things that you found when you evaluated the model?
One of the key points that came up as a strength was that model of proactive follow-up. As I described it, not only the monthly visit, but also the weekly home visit. The patient really responded positively to that follow-up because they felt that they were not alone anymore. All that information that they received on the first day, they didn't have to stress. Somebody was coming along on a weekly basis to remind them and to support them with that. Another strength that we identified was the fact that we were providing glucose machine and test strip to the patient, which was not the case in the public sector at the time when we started the intervention. I should also highlight that the field workers that we had really played a big role, not only in supporting the patient, but also in providing technical assistance to the healthcare provider with on-site job training. So those were really some of the strengths in the intervention. The weakness that we identified were that the materials, unfortunately, that we developed were in English. So the patient couldn't really take full advantage of those education materials that we provided. And that was noted. But also the reliance on smartphone and the availability of a network. As you can imagine, if an app is involved, that means somebody must have network. And sometimes in South Africa, in the territory, we don't have an equitable distribution of the network. So from time to time, the healthcare provider, whether at the clinic or at the home of the patient, were penalized. Also because sometimes the doctor were not always close to the phone to respond to the message that was coming in instantaneously. But when it comes to the opportunities, one of the key opportunities that we identify here was the involvement of allied care worker in diabetes care, namely your community health worker, who could be trained and play a role to link to the home and the facility and the family physician. That was quite beautiful. But we also saw that if we continue like that, maybe training health promoters and other allied care workers, that could lead to tax sharing, because in South Africa, our nurses and doctors are quite overburdened. We cannot rely on them only to fulfill all the tasks that they have to fulfill. So having those allied care workers was very helpful. One of the key threats, unfortunately, that I have to note is that there is a quite prevalent insulin resistance in South Africa, especially in the communities among the patients, but also among the healthcare providers. And it's really through education and mobilization that we can help in that front.
So it's quite interesting what you're saying. I mean, there's two or three things that maybe we can briefly touch on. The one, of course, interesting thing is, okay, so you've involved the community health workers in this, and I note that, of course, they're essentially like then using the app to get input from the family physician or the doctor. I mean, how realistic is it to expect community health workers to actively support the initiation of insulin? It's quite a sort of complicated, isn't it? Sort of medical thing, you know, injections and dosages, and understanding when you have to give it, where you have to give it, and all of this. Do you think that community health workers, I mean, were they able to really support all of that? And I suppose linked to that, before you answer that, is of course the community health workers, they also have usually a nurse, a professional nurse, or a nurse anyway, that is kind of leading their team. Was there a role for the nurse in all of this as well? Yeah.
Indeed, that's a very good question, Prof. We limited the role to non-clinical duties. The initiation in itself was done by the doctor and the nurse at the clinic. What they were mandated to do was not only to support the education message that the patient received in terms of injection sites, in terms of injection technique, in terms of how to measure a glucose meter. We found that when they are properly trained, these are tasks that they can easily do. Now, when it comes to the average team leader, that registered or professional nurse that you mentioned, her role came in mostly when it was about titration. To be on the safe side, we decided that those visits at home, when titration of insulin would be necessary, were conducted mainly by the registered nurse, who is the outreach team leader. Obviously, it might bring some limitation because there's only one per team. But as we found, there were some cases where she wasn't available and one of her team members could do it. As I described, it's just about taking a picture, sending it to the doctor, and the doctor make the clinical decision to say, instruct the patient to increase or decrease. And the community health worker has the capacity to show using the vial to the patient how it should be increased or decreased. So technically, their role was really more on the educational side and to support that titration using the Vula app, limiting really outside of the clinical duties.
So the final question I had, which relates more to the facility-based sort of aspects of the intervention, you know, where you said, of course, that the doctor and the nurse were like responsible for initiating and starting this whole process. And I noticed in the article that, you know, the TIP project provided sort of additional assistance, you know, to field workers or whatever in the clinic, and that they ended up maybe, you know, being essentially providing additional capacity, you know, in the clinic to do the things there that were necessary to kind of get the whole process started. So I suppose my question was, if you take away your field workers, how sustainable would the project be if you were just relying on the usual resources that were available in the clinic? Or does it require this sort of extra input?
So in all fairness, this is a valid question. Our field worker played a big role when it came to supporting the identification of people with type 2 diabetes who required to go on insulin. They also assisted when it came to that first education session before initiation, because it's quite a heavy thing to do in terms of teaching the patient how to inject and when to inject and all that. In average, it might take 45 to 1 hour only for that education. Yes, our concern has been that once you remove the chief field worker, the whole thing might collapse. But we really work closely with the nurse and the doctor to say, first we train them. They know now how to identify and what they need to do. We comforted them that this is not an exercise that they will have to do every day. Once in a while, they might have to spend 1 hour on this patient so that the care is improved. So it's basically about, when we put it in the paper, the attitude of healthcare providers was identified as one of the threats. Some of them really took on the project and became active participants. Others had that attitude to say, no, these are project duties. Although, based on the guidelines, initiating and following up patients is their responsibility. But there was this attitude that we had to struggle on. Bottom line is, if they really take on the project, they are able to identify them, train them, educate them, and follow them up. We didn't really add more to what they are usually required to do.
So Patrick, we probably have to end just now. Is there a final point that you want to make in terms of the implications of your work, something that we didn't mention but is important to maybe just have as a last point?
The role of the health authorities, obviously, in supporting this type of research, translational diabetes research, is very important. That support, because if obviously we come from the university, we cannot give instructions or order to the people on the ground. And as well as when we are trying to do something different, something new, innovative, for example, by including the community health worker in that process, it's the health authorities who should sometimes take on that role to not only see the vision and the what we are trying to achieve, so that they can be the one instructing the staff. The support is very important in realizing what we were trying to achieve and achieving good outcomes at the end.
Yes, so implementing, in a strong collaborative way with the actual health services. Yes, I can totally get that. So Patrick, thank you very much for telling us about the Swani Insulin project and the study that you've published in the Primary Healthcare Family Medicine Journal. And we look forward to hearing more about the outcomes from this project in the future.
Thank you, Prof. Thank you very much for having me.
Thanks.